Okay, so today we're going to talk about eczematous dermatosis. So this covers or correlates to chapter 3, section 2 of Olicon, the Olicon textbook. However, it does not include irritant and allergic contact dermatitis because those are huge topics and there's lots to know. So we'll do a separate video about those more specifically. So let's jump into it. So what is the atopic triad? What are the three classic things in this? So this is atopic dermatitis, allergic rhinitis, and asthma, and they tend to appear in this order. Um, Sometimes food allergies are kind of thrown in there too, but that's not technically a part of the classic triad. Okay, where in the world is atopic dermatitis more common? So it's more common in high income and urban areas, and they think it's because there's a lot of exposure to pollutants and less exposure to infectious agents. When does atopic dermatitis typically start? So there's three different age groups when it can happen. So most common is 1 to 2 years old. And this tends to be more of like the allergic type. And this tends to resolve by 12 years old. And then there's the late onset, which happens after puberty, and then senile onset, which happens after 60 years old. Okay, what two genes are implicated in atopic dermatitis? So it's filaggrin and spink 5. So filaggrin we know is important for epidermal barrier. It can be associated with more severe disease and earlier onset, also food allergies and hand dermatitis. This is the one we kind of more typically think of, but spink 5 you can remember too because that's the mutation in Netherton syndrome, and they get like an eczematous type rash there too. Okay, great. So what proteins and cytokines are associated with atopic dermatitis? So if you think about what the biologics that treat this target, that can help you. So it's mainly Th2 cytokines, so IL-4, 5, 10, 13. So Dupixent targets 4 and 13, Adbry targets 13, and so on. But sometimes you can get more of like a Th1 or a Th22 predominance. And sometimes this even happens when you start the patient on Dupixent, they kind of have some sort of shift that pushes them more towards Th1. So important to keep in mind, but Th2 is the classic kind of inflammation. What is the clinical criteria for atopic dermatitis? So this seems like an easy question, but it's important to know. So pruritus, they have to be itchy and then have three of the following. So history of dry skin, history of allergic rhinitis or asthma, onset before 2 years old, history of skin crease involvement, and then visible flexural dermatitis. So three of those five. Okay, so we're going to match the age of the patient to the typical presentation. So how does infantile atopic dermatitis present? So think about the little babies with the eczema on their cheeks. So favors the face, scalp, and extensor surfaces. So extensor, not flexure. So childhood, this is the more like classic. So favors flexural surfaces, and it's diffuse xerosis as well. Adolescents and adults, these are like the people that are like scratching more, so like kind of fine plaques. Um, can be in flexures, face, neck, upper arms, back, and it may just be at the hands or the eyelids. And then senile, that's when you're older, so that's marked xerosis, pruritus, and it's worse in the evening. So what are the associated features of atopic dermatitis? So this is like associated conditions. There's a lot of them. So it can be associated with xerosis or dry skin, ichthyosis vulgaris, keratosis pilaris, hyperlinear palms, Denny Morgan lines, which are the folds under the eye, darkening under the eye. You can have less lateral eyebrow. White dermatographism is basically like when you test the skin for dermatographism or scratch the skin, you get a white wheal basically at the site. Allergic shiners, which are like the dark under eye circles that are puffy. Pityriasis alba, which is hypopigmentation in the sites where there was eczema. Also, dyshydrotic eczema, which is on the hands and feet, and we'll talk about later. Juvenile plantar dermatoses, nummular dermatitis. There's so many, but it's important to know that these things can be associated with atopic dermatitis. What are the infectious complications of atopic dermatitis? So you can get eczema herpeticum, eczema coxsackium, impetiginized eczema with Staph aureus. So eczema herpeticum is when you have HSV superimposed, and then eczema coxsackium is when you have Coxsackie virus or hand, foot, and mouth superimposed. You can also get molluscum, and you can get eczema like around the molluscum. And then you can get vaccinidum, which is seen with the smallpox vaccine. So the same kind of concept as eczema herpeticum. Okay, what are ocular complications of atopic dermatitis? So you can get keratoconjunctivitis, you can get cataracts, and then keratoconus, which is elongation of the cornea, and you can even get retinal detachment. Okay, moving away from classic atopic dermatitis and more into just eczematous things. How does frictional lichenoid eruption present? So it occurs in the spring and summer in boys on their elbows, knees, and dorsal hands. What are some different causes of hand dermatitis? So anything that can cause a rash on your hands. So it can be intrinsic, so something like atopic dermatitis, or like dyshydrotic eczema, psoriasis. It can be extrinsic, so irritant contact derm or allergic contact derm, and it can be infectious, so tinea manum or staph infection. How does dyshydrotic eczema typically present? So I think one of the main things is that it's like super, super itchy, and you get little deep vesicles on the sides of the fingers and on the palms, and it can happen on the feet as well. And it's chronic and it comes and goes. What are different causes of lip dermatitis? So similar to hand dermatitis, it can be caused by irritant or allergic contact dermatitis. So irritant is most often due to saliva or chronic lip licking. And then allergic is most commonly related to fragrance mix. So things in like cosmetic products like lip glosses and lipsticks. But there's other things in those that can cause it as well. Also atopic dermatitis or just other eczema. What are the classic histopath findings in atopic dermatitis? So it kind of depends on if it's acute, subacute, or chronic, but overall it's going to be a spongiotic dermatitis. So if it's acute, you're going to have prominent spongiosis with intraepidermal vesicles, and then you'll also see mixed inflammation with some eosinophils. For subacute, it's going to be more like that classic spongiotic, acanthotic epidermis. There's not going to be acute vesicles there. And then chronic is going to be more like your LSC kind of thing. So it's going to be a regular or psoriasiform acanthosis with hyperkeratosis, um, with minimal to no spongiosis at that point. How can you prevent the development of atopic dermatitis? So there's a lot of different things that you can do. So breastfeeding, formulas with hydrolyzed milk products for the first 4 to 6 months of life, prenatal and postnatal probiotic, and postnatal prebiotic as well. Also, some studies have shown that daily moisturizer of babies can prevent it as well. And then there's also some evidence for omega-3 supplementation and vitamin D supplementation. Okay, what's the best diagnosis for this? So what I'm seeing here is a rash that's scaly that looks like a cracked riverbed. So this is aciatotic dermatitis. So basically you have decreased natural moisturizing factor, which leads to dryness, scaling, cracking, and it's usually on the legs and it's itchy. What's the best diagnosis for this? So this one looks like a round coin-shaped plaque, with probably some scale and maybe like a couple erosions. So this is nummular dermatitis, which nummular means coin-shaped. Um, so this can be associated with external irritants, venous hypertension, atopic dermatitis, cirrhosis, and it's very itchy as well, and most commonly on the extremities, but it can be on the trunk. How does progesterone dermatitis present? So, as the name implies, it is triggered by progesterone. So, it alters with the menstrual cycle. It flares during the luteal phase when the progesterone is high, which is 1 week before menses. And then it resolves a few days after menses. And it can kind of look like anything. It can be urticarial, it can be more vesicular, you can have oral erosions, lots of different possibilities for what it can look like. How can you test for if somebody has progesterone dermatitis? So basically, you just expose them to progesterone. You do an intradermal injection and then they get a skin reaction from that. Well, how do you treat it? So basically, you want to prevent ovulation, so you can either do oral contraceptive pills or tamoxifen. How does estrogen dermatitis present? So again, varies with the menstrual cycle, but this one flares right before menses, and you can also treat it with tamoxifen. Why does this condition develop? So first of all, this is venous stasis, or stasis dermatitis, I should say. So this is related to incompetent venous valves on the lower extremities. So your veins, are not bringing the blood back to your heart. So you get venous hypertension, which then causes edema, hemosiderin deposition, fibrosis, and then in response to that, you get inflammation and you get new blood vessels forming. You can also get ulcers from this. So basically, because the blood is pooling, all of these things are happening. What are complications of stasis dermatitis? So I just told you ulceration is one. You can also get super infection of it, contact sensitization. So these patients can develop allergies to things like lanolin or topical antibiotics, lipodermatosclerosis, which is a form of paniculitis. Um, and then with the ulceration, it's most commonly at the medial supramalleolar region, so right above your medial malleolus. What are the histopath findings in stasis dermatitis? So sometimes you'll see a biopsy from a leg, and it can be hard to tell exactly what it is because they have underlying stasis dermatitis as well. So it's a spongiotic dermatitis, and then you also see increased capillaries, hemosiderin deposition, and fibrosis of the dermis and the subq fat. How do you treat stasis dermatitis? So the number one thing is compression. So whether that's compression stockings or they have like all sorts of different devices now too. You should elevate the legs. You should moisturize them. You can do topical steroids if they're itchy. And then you can also do Danzol or pentoxifylline for lipodermatosclerosis. What is autosensitization or an id reaction? So this is basically like when you get a secondary eczematous dermatitis in response to another rash that you have going on. So I've seen it to tinea capitis, but it can also happen with allergic contact derm, stasis derm, tinea pedis. So it tends to be ill-defined and symmetric. Um, and usually it happens like after the original rash. What are risk factors for contact urticaria? So, atopic derm, hand dermatitis, allergies to fruits, which we'll talk about in a little bit. And this is most commonly seen in people that are in high risk occupations. So, healthcare, food handlers, hairdressers, dental assistants. What is the difference between immunogenic and non-immunogenic contact urticaria? So, as the name implies, one is immune mediated by IgE and one isn't. So, immunogenic, that one, you have to have the specific antibody to it, and it's associated with anaphylaxis. Versus non-immunogenic, anybody that's exposed to it would get urticaria, and this is a much lower risk of anaphylaxis. What substances can cause immunogenic contact germ? So it can be raw vegetables and meats, so potatoes, celery, fish, latex, ammonium, which is in hair bleach, henna, bacitracin, and cow dander. Who's at risk for latex-induced contact urticaria? So one that seems pretty straightforward is healthcare workers, but also spina bifida patients and atopic dermatitis patients. And sometimes aerosolized glove powder on mucosa or mucosal exposure can induce anaphylaxis. So you have to be really careful in these patients not to have latex gloves around. What substances cross-react with latex? So this is the mnemonic back passion. So it's bananas, avocados, chestnuts, kiwis, and passion fruit. So a lot of different fruits and chestnuts too. What substances can cause non-immunogenic contact urticaria? So again, this is anybody who comes into contact with this will get contact urticaria to it. So this is like the stinging nettles, jellyfish, caterpillars, DMSO, benzoic acid, cinnamonic aldehyde, so all sorts of different things. How can you test somebody for contact urticaria? So basically, you just put it on their forearm and see if you get urticaria from it. So you just have to wait 30 minutes. If you don't see anything, wait 30 more. But this can test 75% of, or can detect 75% of latex allergies. What's the treatment for contact urticaria? So obviously, you want to avoid the substance that's causing it. You can also do antihistamines, systemic steroids if it's really severe, and then make sure that they have an EpiPen in case of anaphylaxis as well. And that is it. So we will be talking about allergic contact dermatitis and irritant contact dermatitis soon.